I just want to preface this with saying that I am not an expert in dry needling. I have not done it myself. I haven't taken the training on it. But Dr. Shaw asked someone to research it. So it is something that physical therapists do. So I'm a little bit aware of it, but I had not really investigated it much. So I thought it would be interesting. So just so you know, I've not done this, but we'll go ahead and get started. So dry needling, it also goes by the name of intramuscular manual therapy. And the definition's pretty wordy, so I'm just going to read it out. But it's a skilled intervention that uses a thin filiform needle to penetrate the skin and stimulate underlying myofascial trigger points, muscular and connective tissues for the management of neuromusculoskeletal pain and movement impairments. So that's a little bit of a wordy definition, but I'll go through a little bit of the history with you. So my understanding from what I've read is this is a lot like some techniques in acupuncture, and acupuncture's been around a very long time. They call it something different, but around about the 1940s, a doctor by the name of Janet Travall, and if you've ever done any sort of manual therapy, she's like a big name in manual therapy techniques. She sort of like developed this technique, kind of westernized it, and based it less on energy and chi, and took away the Eastern philosophical component of it, and pretty much just looked at the anatomy and physiology. And so she basically found that there's these trigger points, and she used different kinds of needles at that time, but she was doing studies and showing that if you put needles directly into this trigger point, that it has a positive effect. So it's kind of based in that. And then it didn't really take off until like the 1980s. It's done in other countries, like in Europe. I think Canada does it, but it wasn't used here until about 1984. The American Academy of Orthopedic Manual Physical Therapists, their position statement really didn't come until 2009 that it was included in the scope of physical therapists, manual physical therapists. And those would be physical therapists that have had advanced training in manual skills. So it's not really an entry level thing that all physical therapists come out of school knowing how to do. The Federation of State Boards for Physical Therapy, which is, again, that's a conglomeration of all the state boards in the country. So they kind of came together in 2010 and had a position statement that supported it, that it should be included in the scope of practice for physical therapists. And then, of course, the American Physical Therapy Association, they came out with their statement in 2012, supporting that physical therapists should be allowed to do it with training. Again, not entry level, but advanced training. And then the American Medical Association came out with their position in response to that in about 2016, calling for more regulation and more kind of control, and just basically they're concerned that it's considered an invasive treatment because the needle's actually going into the tissue. So they're calling for some more regulation on it, and they don't feel that physical therapists should necessarily be doing this procedure. So that's just kind of the general history of how this came to be. So for those of you who don't really know, just a quick review of what is a trigger point anyways. So this picture, you kind of show like you're looking at the trapezius muscle. That's the red muscle there in the diagram. So you come out a little bit, zoom in a little bit, and then you'll see there's like a muscle fiber band, and then go in a little bit more, and now you're looking at the actual like muscle spindles, very small, tiny parts of the muscle. So this is where you get what are called taut bands, or these little bunches of this tissue. So instead of being like these nice long fibers like you see, kind of all running parallel, you get these spots in here that are kind of lumped together, and they can't relax, so they can't lengthen back out. And so they can be kind of all over, but again, this would be too small for you to feel one of those with your hand, but a bunch of those together, you would start to be able to palpate from the outside. And that's what we would consider a trigger point. So physical therapists are pretty good, massage therapists, are pretty good at finding these. It's not hard to find them once they're big enough, and they can occur in any muscle really. So this is just kind of the rundown, I guess, instead of the picture. But so the development of a muscle fiber contracture or this taut band can be due to injury. It can be due to an unaccustomed eccentric or concentric loading, like if you overexercise or overlift something or strain something. Low load repetitive tasks, so any kind of repetitive movement can cause these to develop and create more and more. Sustained postures, overall stress of some kind. People tend to tense up and then they can't relax, and that's more of a subconscious thing, but it can also affect it. So there's some theories about what causes them. Nothing's really been proven. They've done some studies, animal studies and things like that. So there's a couple different theories, but mainly it's talking about when you get these taut bands, there's an excessive release of this acetylcholine at the motor end plate, which is kind of the little deep down in the muscle. And so that causes like extra what they call noise. So there's electrical activity that can't stop. And so normally when muscle contracts, it relaxes, that activity stops. And in this case, that activity just keeps going because there's more of a buildup of that acetylcholine. Also, when that happens, there's also some mechanisms which are really detailed, and I'm not going to have time to go into it, but with the nervous system, both peripherally and centrally, in the brain, spinal cord, nerves, and even very much at the nerve endings in the muscles that cause them to be sensitized, which means they get hyper responsive to pain. So they're getting extra input and they're getting extra stimulation, and then that can be the constant source of pain that is perceived by the patient at the end of this whole process. So some of the complications of trigger points, why we would treat them anyways, would be that they can actually cause inhibition of the muscle that they're in, so the muscle can't contract and relax properly, which can lead to atrophy, which we know can lead to a lot of other problems with mechanically. If now you don't have muscles working right, now things are getting off balance, which isn't good. Then, of course, you have the inability of the muscle can't lengthen anymore very effectively. So now you might lose flexibility in the nearby joints and in that muscle. And then that also, another part of this is this tissue hypoxia. So when these little taut bands are all bunched up, they're not relaxing, the blood flow can't go in and out very well. So the tissue becomes, less oxygenated, which that can also cause atrophy and pain on its own. And then that increase in ATP, which that's from damaged tissue. So that kind of accumulates in that area, which that also causes pain. That whole situation then causes the tissue pH to go down, becomes more acidic, which that causes more pain and damage. And then you can also get compression of the nerves in the area, blood vessels that are in the area, and that can cause more pain. So there's a lot of things, a lot of reasons why these trigger points can be pretty problematic. And for those of you who would prefer a picture version, this is kind of the same thing I just went over, but I'm a more visual diagram person. So if you start at the top, we talked about that stressed motor end plate where there's that extra noise going on, and that can lead to that release of excess calcium, and this gets really detailed, but and then it starts to release this whole cascade of different things that are irritating to the muscle and the nerves. The pH goes down, circulation is impaired, you don't have good oxygen or nutrients, it's hard to remove waste products. So you get more of a buildup of that, which causes an increased metabolism and energy demand in that muscle. That causes more pain and dysfunction. And then again, the increased stimulation of the sarcomere, which are the very, very small parts of the muscle fiber. They get stimulated, so they're tightening up some more. And it kind of just goes from there. So then you get this taut band, And then contraction nodules, that causes it to go around and around and around unless you can somehow stop it. So there's lots of different ways to stop the cycle, but dry needling in particular is aimed at stopping this cycle. So it's kind of interrupting a lot of those things, and that's kind of how it works. So how does it work? Well, no one really knows for sure. There's a lot of theories of what's going on, but no one really knows for sure. So one theory is that you're literally mechanically breaking up adhesions with the needle, which can help with some of those issues. Some of it is just by placing the needle into that area, you're interrupting the pain signal so that you're going to reduce that input to the nervous system and kind of stop that cascade of all that chemistry that happens below the surface. That would inhibit that motor end plate noise, kind of calm things down a little bit neurologically. Maybe it's just helping the taut bands to literally relax and stretch out. It can normalize the pH of the tissue. And then there's that good old-fashioned placebo effect, that it could just be that someone knows they're getting treated for it, and therefore they expect it to help, so it helps. You know, that's always a factor in there that kind of confounds research to prove anything. So what do we use dry needling for? The major thing is myofascial pain syndrome. So any kind of pain that's kind of non-specific, muscle, tendon, that kind of fascia. Radiculopathies, migraines, muscle tension headaches, carpal tunnel syndrome, whiplash, phantom pain when someone gets an amputation and they're having a lot of neurological pain, and then complex regional pain syndrome, which I'm a little surprised at this one because people with this are in such severe pain that you can't even barely touch them. So although the needles are small, I would wonder if they would really tolerate putting something or any pressure moving around an area that is that painful. So, I mean, I've only had a couple patients like that, but I could not imagine convincing them to let me put a needle, no matter how small, in that area. So, but apparently it's been done. So some of the precautions for the dry needling would be a needle aversion. Sometimes you can talk a person through it. So if you can work through it, you can still do it. If there's a significant cognitive impairment, you know, they're not going to really necessarily be able to give consent, or they're not going to understand, or they may not cooperate with what you're trying to do, and they need to be still when you're doing this procedure. So if they don't understand that, you can have some complications if the needle doesn't go into the right spot. Local lymphedema, you don't want to disrupt that and make that any worse or create any more. Any kind of metal allergies, because the needles are metal. So apparently they make silver or gold-plated needles. So that sounds really expensive. But I guess if you have a metal allergy, you might need a gold-plated needle. So I'm not sure where you get those, but any kind of, this one, it's mentioned in both a precaution and a contraindication too, but abnormal bleeding, orthoron, anticoagulant therapy, it's not always a total contraindication, but I guess if they just have a little bit or it's not severe, you might be able to get away with doing this because it is a really small needle. So they're probably not going to bleed out from this. But, you know, you do have to keep it in mind as far as how aggressive you are with the technique, because there's different ways of doing this, and I'll talk about that in a minute. So you might pick one technique over the other if someone has a little more, is prone to bleeding. Of course, if you have a compromised immune system, you know, you're probably not going to want to take the germs that are on the outside of their skin and put them in. That can cause infection, of course, always. And this isn't really, it's a clean technique, but it's not a sterile technique. So you always have a risk of infection on that. Pregnancy, of course, we never want to do anything to someone who's pregnant. So although it's not a contraindication, there is a part of it that is. But so if you're doing it in an area that's away from the abdomen or the back, you do have to avoid some areas that can stimulate things start to happen as far as contractions. But so it's a precaution, but And then following surgical procedures, again, it's not a total, like you can't do it, but you do have to be careful where you're doing it, how close you're doing it. You don't want to disrupt any healing. You don't want to, hit anything that's been cut and it's trying to heal. So here we have the contraindications. So this is where that hyperalgesia, which is like the complex regional pain syndrome patient who just has such severe pain that you can't even touch them, that's a contraindication. So I was a little confused as to how that worked, but so the person has to be able to tolerate a little bit of pressure. It's not supposedly a painful procedure, but you would have to tolerate a little bit of pressure and movement. So generally not done on children. And again, the back, abdomen, pelvis in pregnancy. So I suppose if they had something up in their upper trap or something, you could do that. Any kind of reason why they can't give consent or understand what is going to be done to them. You can't needle deep muscles if the person is on anticoagulant therapy or has thrombocytopenia or abnormal clotting, because you can't get enough pressure afterwards to stop the bleeding. You can on more superficial muscles. Any kind of vascular disease, you don't want to do this on, obviously, for obvious reasons. And the needle, and this gets to the surgical thing, but the needle might not be directed at a joint capsule, especially postoperatively, or any kind of implant. So you don't want to disrupt any of that. So there's another technique that you can add to the dry needling, which is using electrical stimulation. So and I'll show you that in a little bit, but they put the needles in the muscle in the trigger point, and then they run electrical current through it to try to get a muscle contraction. So that brings a whole nother list of contraindications because of electrical stimulation, which are the same ones that we already know that we use for regular electrical stimulation just on the surface of the skin. So obviously a needle or electrical stimulation phobia, not just an aversion, but if you can't get past it and they're just really upset about it, it's not going to be really effective. We generally don't do it across the spinal column where the spinal cord is. You don't want to do this anywhere near implanted electrical devices because the electricity will obviously disrupt that. And if it's a pacemaker, you really don't want to disrupt that for sure. Again, same thing with the back, pelvis, abdomen during pregnancy. We don't want to do really anything. We can't even really do hot packs. I mean, we're just not supposed to do anything in that area. You're not supposed to do it in the neck area. You don't want to be messing with carotid sinus and heart things and laryngeal nerve, really important things that you don't want to be stimulating inappropriately. And then you don't want to do it in an area where the person has no sensation, because they have to be able to feel the intensity so that you don't burn them. So as far as the procedure, there's a couple different ways of doing it. Like I said, apparently one way is this, I think it seems like the most common way that I've seen in just researching it, is this dynamic way of doing it where they put the needle in and then there's a slow, steady like movement, pistoning of the needle. There's a static version where they just put the needle in and leave it in, which is a little more like acupuncture. And then there's like more of a rotational where it's dynamic. So they're going in and out, but they're doing it kind of in a circular rotational pattern. So in case you were wondering, what are the size of these needles? So this is just a little comparison of, how small are they? So they're a lot smaller than a matchstick. They're very, very small. Now they do make different lengths for going different depths. So some of them might be as long as a matchstick, but they're not as big around, obviously. And it says here, most patients feel no discomfort. Most. So... And then, so this is just kind of a rundown of the general procedure that's recommended. Patient's positioned so that you can, access the area. You need to clean it with alcohol. So again, it's not a sterile technique. They do use gloves and clean the area, but that's about it. Then you manually palpate and locate the trigger point and pull it away and squeeze it if you can to get it ready for the needle. And then there's a certain way of inserting the needle, and then you decide which technique you're going to apply. You apply your technique. And then there's some a lot of variation in how long you do this for. So you might do one muscle for 30 seconds and that's it, or 60 seconds, or you might do that 30-second, dynamic thing and then leave it there for 15 minutes or so. You might add the electrical stimulation for a couple minutes. So there's really no standard. It's sort of this is one of those things that's not really well developed. So it sounds like there's just a lot of different ways people do this. And then you would take the needles out, and then you have to compress the tissue for 5 to 10 seconds. Most people, possibly more if someone is showing that they're bleeding. And then I'm going to show you this. This is like an educational, it's like a 3-minute. This is the longest video I have, but I thought it kind of was a good example. And there's going to be a narrator who's going to have a very gentle voice, and he's going to describe this to us.
This video looks at the dry needling for the trapezius muscle. Innervated by the accessory nerve, the upper fibers of trapezius can refer pain ipsilaterally from the posterior lateral region of the upper trapezius to the temporal and mastoid area. Trigger point activity in the middle fibers of the trapezius can refer pain into the interscapular region and out towards the acromion process. Trigger points in the lower fibers of trapezius may refer pain to the posterior cervical and mastoid region, out towards the acromion process, with some spillover into the interscapular region. With the patient in the prone position, this muscle should be needled in a posterior to anterior direction. Pneumothorax, as a result of the needle penetrating the lung, is probably the most serious adverse event possible in the area. To minimise this risk, the needle insertion or any needle manipulation should be done with a pincer grip palpation of the muscle belly. The anterior and more medial trigger points should be needled in a posterior to anterior direction. The more lateral trigger point should be needled in a posterior to anterior and cephalad direction.
Just wait.
With the patient again in the prone position, with the arm resting by the side, the trigger point torque bones in the lower fibers of trapezius can be palpated for. The area can then be needled at an acute caudad angle. This superficial method should again reduce the risk of pneumothorax. Torque bands in the mid-fibers of trapezius should be palpated for and secured with middle and index fingers over a rib. The area should then be needled in a medial to lateral direction at an acute angle towards the spinal scapula.
And I think this is the one they add electrical stimulation to. So you can see what that looks like.
So we have Patricia set up here for the treatment. So including my hands here. I've already inserted the needles in L4 and L5. L4 on the left, L4 on the right, and L5 on the left, and L5 on the right. What I'm going to show you is how we stimulate it with our stim machine here. So basically what I do is I put the ground on the one side here on the right, and I'm going to stimulate the left side. And you can really see a good contraction, tapping going on. And basically we're going to stim that for about 10 or 20 seconds, and we can do that at each segment that we have the needles in. This is just showing L4-5. We can do multiple, we can do the whole spine if we need to. And what this will do is try again to help release those muscles and release that back pain tension.
Okay, so now that we all have a visual on what's going on here, you can see how there's, it's invasive. I think most people after seeing that would say, oh, that's kind of invasive. It's not just like tapping a little needle in and leaving it alone. So this is where the discrepancy comes in as to who can do this procedure. So it really depends. So every state has a different law and practice act for different professionals. So in some states, some people can do it, in some states, others can't. So it's really kind of all over the board right now as far as who can do it. In general, acupuncturists for sure can do it. It's very much in their scope of practice. No one really disputes that. And they have, it's a master's degree program in most states in order to sit for that licensure exam. So they have, I think, roughly anywhere from 1,000 to 3,000 hours between classroom and actual, clinical work. So they don't just do dry needling, they, do other procedures, and they don't call it dry needling, they call it something else. But anyway, so acupuncturists pretty much can do this in any state. Physicians, physician assistants, nursing, all kind of fall into this category. They can puncture the skin, they can do invasive procedures. So it's not really a yes or no per se on this specific one, but it's generally considered it would be, with some training, it should be in their scope of practice. So there's not a lot of debate whether they can do it. Physical therapists, there's a little bit of debate from the different states as far as who can and can't do it, as well as chiropractors, because both physical therapists and chiropractors typically don't do anything invasive and don't puncture the skin. So the training, again, it depends. It varies by state. So sometimes for a healthcare practitioner other than an acupuncturist who wants to do this, there can be a minimum requirement of 24 to 50 hours of training to do this. And some states require 100 or 300 hours of training. So it really depends on the state, really. So this is just as far as physical therapists, in which states physical therapists can or can't do it. So the green is yes, they can. So there's a lot of states where it is legal for physical therapists to do this. The red states are absolutely not. They can't do it. The yellow ones have conflicting laws, apparently. So I'm not sure what that means. And then there's this white category, which is us in Michigan, which is completely unknown. So apparently we have no idea what we're doing. There's no for or against, there's just nothing. So we're kind of all over the place. So there are therapists that do this in Michigan. Yeah, so I think it's catching up. There will be something happening soon, because even just reading through the MPTA board minutes and the Federation of the State Board for Michigan, or not the Federation, just the State Board of Physical Therapy for Michigan, they've been meeting on this, and even as recently as January are starting to develop procedures and things that they're going to put forth for the licensing board to require physical therapists to do. So I think it's coming. There's just nothing on the books yet. So just to kind of recap a little bit, what is the difference between dry needling and some other therapy types? So with dry needling, we know we're using a very small solid needle, no medication, nothing's injected, it's just the actual mechanics of the needle. Trigger point injections have to obviously use a larger hollow needle, and they're actually so that they can put medication into the trigger point. And I've not seen a trigger point injection, but I'm pretty sure they don't move all around and do it. They just go in, give the injection, and get out. So the very different approaches to that. And then, you have your traditional, good old-fashioned manual trigger point release, which therapists have been doing for a very long time. And it still gets to the same endpoint. There's still the same chemical reactions that happen in the skin. There's still the same mechanical things that are happening from the trigger point release, but we're doing everything from the outside. So we're still palpating the trigger point, we're still finding it, we're still applying pressure. We might use tools, but nothing that punctures the skin. So I'm not really entirely convinced that the needle is just supposed to make it more specific. But I mean, when I palpate a trigger point, I can feel that twitch, that twitch underneath the skin, and I can tell when it slows down and stops. So, but that's just kind of the overall difference of what this is. And then I didn't put it on here, but acupuncture we kind of talked about on and off. They call it like a lift and thrust method, but it's basically the same thing as what they're doing. So, as dry needling. So, there's a lot of controversy right now kind of about this in the physical therapy profession specifically, but because it's kind of still relatively new. So the biggest thing is that acupuncturists and physician groups are protesting this in some cases, even after, the state board of whatever state it is might say it's within the physical therapy scope of practice for that state. There's still legal fights that happen. So there are other professions that say, hey, you're on our turf. You're not qualified to do that. You shouldn't be puncturing the skin. So there's kind of this debate that goes on. There have been some states where it was approved by like the physical therapy board, but then there was law that came out that said, no, you can't do that. So this issue of puncturing the skin, this terminology seems to be really sticky. Like that's what gets people hung up on, legally speaking. So, and invasive procedures are typically not within a PT or a chiropractic scope of practice, which we said before. So, the acupuncturist scope of practice infringement lawsuits will follow. So even if we get it to be sort of legal, approved for the physical therapists in Michigan, I wouldn't be surprised if there was a little bit more debate about it. So a couple of just issues that I also came up upon were billing issues. So if a physical therapist did want to do this, there really isn't a CPT code for dry needling. So some practitioners use the manual therapy code because they're feeling like they're manually finding the trigger point, they're holding the muscle, they're manually doing this technique. They're just using this needle to assist them in this. But there's a debate because it actually is something different than just traditional manual therapy. You're putting something in the skin. So there's a little bit of, is this fraudulent? Is this not fraudulent to just call it manual therapy just because we have no other code for it and we know we'll get reimbursed for manual therapy? So the APTA actually recommends that you use this unlisted physical medicine procedure, which there is no reimbursement associated with it specifically. Like we know for therapeutic exercise, you typically are going to get this amount. There's nothing for that, so you may not get anything, and it's probably going to be a very low reimbursement because it's sort of generic and not very specific. And you also have to submit documentation to even get them to consider this sort of unlisted code. But then there's always the private pay option. So that's, I think, what ends up happening in some cases is people are willing to do it out of pocket. So, and then this one's for Dr. Shaw, but he's not here. So I know he wants to know about all the research. So I looked into it. There's not a lot of research out there, not of high quality. It's really hard to make these large-scale double-blind studies, because it's really hard to get a control group that is getting a sham needle because the needles, you have to almost replicate it. And when the needle going in is the treatment. So if you pretend that you're putting a needle in, who's to say it's not a very good setup for a study. So that's one problem, and it's just kind of new. So there really isn't a lot of high-quality evidence, but there is some low to medium quality evidence that does support it. There's just a lot of case reports and a lot of anecdotal evidence. I know some people that have had it done and it really helped them. So that's out there. So it's not that it's not beneficial, but they just haven't really been able to prove it on a large scale yet. And then all of it kind of basically is in agreement that dry needling shouldn't be used as the standalone treatment in and of itself. So it is something that you could use as an adjunct to everything else you're doing with your patient therapy-wise, but you would still need to do stretching and strengthening and postural re-education and all these other things in addition to just the dry needling. So that's it. So if you care to know more, there's some references here if you'd like to investigate more.